Our agenda tonight, we're going to go through several updates from some of our state partners, including a couple of presentations from folks from the Oklahoma State Department of Health. And our first update is going to be from the Oklahoma Healthcare Authority. So I'm going to let Falake Adedeji, I'll turn it over to you, Falake, for your update. Thank you.
Thanks, Denise. Hi, everyone. So I'm standing in for Trailer this evening, and I'm going to be providing the OHCA updates. One of the things that we wanted to bring to the group this evening was to kind of talk about the CMS's transforming maternal health model. Towards the end of I never asked how long I have, Denise. How long do I have?
I think 5 to 10 minutes.
Okay. So towards the end of last year, CMS put out some information around wanting to improve maternal health outcomes in rural America. And we kind of, got wind of the information, and we internally in OHCA, we started talking about whether this was something that we wanted to do or not. As we talked through it and just looking at the landscape of our state and how, we knew we could, work better on our outcomes or improve our maternal health outcomes, we got to a point where we had decided internally as OHCA that we were going to apply for the grant. And so about 2-3 weeks ago, CMS put out the nuts and the bolts of the notice for funding. And we have a work group that it has the health department and some other partners within that work group. And we've been working to kind of take apart what CMS wants to see in the grant. We've also spent some time working internally to look at the programs that we have to see what we could scale up. So the model itself kind of focuses on several pillars like health inequities, health-related social needs, chronic health needs, workforce and infrastructure. And CMS is hoping to fund up to 15 states over 10 years to a tune of about $70 million each. One of the things that's come up is the George Kaiser Family Foundations offered us grant writers to help us with the grant writing to a point where we're just pulling the data and the information and sending it to them, and they're writing, and then we'll be reviewing. The grant is due September 20, but before that, there's a letter of interest due August 8. So we're kind of working through that process right now. Recently, the Oklahoma Medicaid OHCA was invited by CMS to present in one of their webinars. We had a few years, well, I don't know if it's a few years, but maybe a year or 2 years ago, we had participated in a project that focused on hypertension and cardiovascular issues during pregnancy. And so they had sent us an invitation and asked if we would like to present on our strategies to address perinatal cardiovascular conditions. The presentation took place this afternoon, and we had the nurses that ran that project present to other states and other Medicaid agencies on what we did and how we did it. If anyone's interested, you could reach out to me. I'll try to get you the recording, because they typically record those things and they send it back to us when the webinar is done. The other update that I wanted to give you was that with doulas, we've been working to kind of revamp our doula certifying organization criteria. For the longest time, we noticed that we didn't have as many doulas contracted as we wanted. And so we've been reaching out to the doula communities and trying to encourage them to contract with us, because we know that we can leverage them for better outcomes. And so we also took a look at our criteria, and we kind of redid it so that we could allow more doulas to contract. And so we're currently in the process of making rules, because if we redo any criteria or we put any criteria in place, we have to have rulemaking around that. So we're in the process of rulemaking around that, but all of that to say that we've kind of tweaked it so we can have more doulas contracting with us. And then the last update that I has to do with a bill that got passed this legislative session. And it's a bill around birth centers and midwives and some of, things like that. And once the bill was passed, everyone was looking to OHCA to provide the rules around how that was going to work. I just heard from our policy department that we just got approval internally to go ahead and create a work group of internal and external stakeholders, as well as start the process for rulemaking. So all of that is kind of in the works. Those are my updates. If anyone has any questions, I'll be happy to answer them. If you have questions after, I could pop my email in the chat and you can send me an email if you want to. So thank you.
Thanks, Falake. You stayed well within your time limit, so we do have time for questions if anybody had any.
Hey, Denise, it's Becky. I may have missed it. What was the Senate Bill 1739? Just the gist of it? Sorry.
So it was, and I think Priscilla is on here. She can help me with it. But it was,
Sure.
Priscilla, are you on? Yeah, you're
Yes,
on.
I am on here. I'm on
Please
here.
help
Can
me.
you guys hear me?
Yes.
So Senate Bill 1739, it modified the licensure statute from 1992. None of the birthing centers had been licensed. And so the new statute is going to give birthing centers an option to become accredited by the National Accreditation, which has higher standards of care. And once they are accredited, then they will be deemed licensed by the state of Oklahoma, and then they can apply for reimbursement from Medicaid.
Gotcha. Okay.
Thank you.
That's a big change. So yeah, thanks for that update. Any other questions? Okay, as you can see, her email address is in the chat. So thanks again for that update, Flocking. Next, we have Joyce Marshall, who's going to provide us with some updates from the Oklahoma Maternal Health Task Force.
Denise, and I just have a few updates before we turn it over to our presenters. So I just wanted to let everyone know that we are currently applying for the ERASE grant, which is kind of tied to maternal mortality review for the state of Oklahoma, working with the national, and also the next reiteration of maternal health innovation grant. So hopefully we'll have some good news to share with you soon in relation to that. Also, our maternal health morbidity and mortality report, the annual report should be out in the fall. We're working on that right now, and we'll have that information to you in a recap following. Also want to let you know that 211 is now providing direct assistance and information in relation to assisting with Medicaid enrollment and re-enrollment for eligible pregnant postpartum women, as well as connection to maternal and infant health resources. So this is something we've been working on with the Healthcare Authority and Communications Group to actually provide another resource, as well as our county health department. So this is another avenue that's open, and just wanted to let you know about that. And also just kudos out. I want to give a couple kudos to OPQIC and some of the hospitals in relation to the A1 obstetrics and emergency department simulation training. It was wonderfully done, very well done. And I think Katie said 33 hospitals and 5 other organizations were represented in those 4 trainings throughout the state that were done the last week of June. So just wanted to give a kudos out in relation to that, as well as that the teen birth continues to grow to all birthing hospitals in Oklahoma. So those are both really wonderful items, and just wanted to share that praise.
Thank you, Joyce. We appreciate that. That has been a lot of our hard work lately, for sure.
A lot of hard work for all involved, and just deserve all the kudos. I now want to turn it over actually to my esteemed colleagues and our two key OSDH speakers for today on requested topics of interest. So first, you are going to hear from Amber Rose. Amber is the Interim Director for Sexual Health and Harm Reduction Service at the State Health Department, and she's going to be talking on syphilis in Oklahoma. And then following her will be Kelly McNeil, who's the Pregnancy Resource Navigator Program Coordinator for the Family Support and Prevention Service. They both have excellent presentations and information for you today. So Amber, I'll turn it over to you.
Thank you, Joyce. Can you hear me?
Yes.
Okay. All right. So I'm just going to take a little bit of time to talk about syphilis in Oklahoma, and I'll go pretty quickly probably, because this is sort of a precursor to something that we would like for all of you to participate in October. Trying to advance. There we go. I'm going to start with primary and secondary. So Oklahoma has actually been in one of the higher morbidity areas for primary and secondary syphilis, as well as congenital. In 2019, we were ranked 5th. In 2020, we were ranked 4th. In 2021, we were 4th. And in 2022, we were also 4th for the highest rates of primary and secondary syphilis. Primary and secondary, I'm not going to get into a lot, but those are the earliest and most infectious stages of syphilis, and they are the best indicators of what's really happening right now in Oklahoma. So that's kind of why we report everything out as primary and secondary. We have obviously been increasing over time. We tied the national rate in 2017, and then you can see that we have surpassed the national rate quite significantly. We're seeing increases in every age group. Syphilis is kind of unusual in that, you know, normally with chlamydia and gonorrhea, and even sometimes with HIV, you see the exposure age range kind of stay in the same area, and it's actually not really the case with syphilis. It's kind of all over the place. Some years you'll have a higher rate among 25 to 29 years, and then other years will have 30 to 34, but you can see that it does have a lot of age distribution. We do see it in a lot of age groups. This is actually just going to kind of show you progress over time. It shows you how far, I guess, we've come since 2011. So for 2022, Adair County, Caddo County, Seminole County, Mays County, and OPQIC County had the top 5 highest rates of primary and secondary syphilis. And some of those counties are really small, so even a small number of cases are going to cause some pretty high rates. We did have a pretty huge syphilis response in Caddo County in 2022, and really in 2021, we had a huge response in Carter County. So we've had increases in a lot of those smaller counties that are pretty concerning. When we look at the rate of primary and secondary syphilis by sex and sex of sex partners, you see this increase in women, which of course is going to speak to our increase in congenital. And then MSW is men who have sex with women, and MSN is men who have sex with men. So you're going to see increases in all 3 of these. What's interesting about this really is that we've got a lot more heterosexual transmission that started occurring in Oklahoma really around 2017. And right after that, it started kind of increasing, and we saw it more among our heterosexual population than we used to see. So of course, this is going to lead to an increase in congenital syphilis numbers. So we do have 2022 data available, and I should mention that 2023 data actually doesn't close out until we sign off in August, the beginning of August, and that's when we'll have 2023 numbers available. So really all that's available right now is 2022. We did rank 5th in the nation in 2020, and we ranked 6th in the nation in 2021, and then 5th again in 2022 for rates of reported cases by year and year of birth and or stillbirth. So again, really concerning, and really why we're having this conversation.
Amber, I just wanted to mention, I don't know if you can see the chat, but we
Oh,
did
I can't.
have a question that said, back to your breaking down between men and women, does this mean that overall men have higher rates when those are combined?
Oh, yes, there's more cases among men than there are women. That's actually been the case for a long time. It's really just the increase that we see in the sexes, or in the sex and sex of sex partners, that's the most concerning when we're talking about congenital syphilis. I mean, it's all concerning. The numbers are all going up in all three of these categories. It's just really creating a solid ground for congenital syphilis cases to happen. But yes, typically there are more cases among males than there are females. We're just seeing increases in our female cases. Does that answer the question?
I think so,
Yes,
yes.
thank you.
Okay. So then of course here you have your syphilis rate among females shown in that orange. I think it's orange on y'all's screen. As those increase, we're seeing an increase in congenital syphilis cases in Oklahoma. So the light blue at the top actually represents the number of stillbirths out of those cases, congenital syphilis stillbirths, and the number of cases that are just classified as congenital syphilis. And I actually think I'm going to take a second and just kind of explain what those numbers mean. So when you have a case of congenital syphilis, it doesn't mean that the baby is born with very clear and obvious signs and or symptoms of congenital syphilis. It really means that it was possible, that the intervention didn't happen in time for those cases, that it was not an ideal treatment timeline for the mother, that it wasn't administered in time for it to also treat the baby. So it doesn't mean always that they were born with obvious congenital syphilis. They met a case definition that caused them to be in this category. And that case definition includes really things like the mother not being treated on time, which is just automatically a case. The mother is not treated 30 days or more before delivery. The infant ends up a case of congenital syphilis, regardless of whether there are any signs or symptoms, regardless of whether testing is negative in the baby. That's just how the case is classified. It really just is a way of identifying the fact that we had some sort of missed opportunity with treating of the mom. We missed some sort of ideal timeline, and now we have a congenital syphilis case. Alternatively, there are some cases where the mother is treated appropriately in time, but then for whatever reason, maybe there's a reinfection that was unidentified, maybe just some level of treatment failure, just something about the whole situation. The infant can still be classified as a case if there are testing results done on the baby where there's an RPR that's reactive and there's some other sign or symptom present. And so those other signs or symptoms are things like snuffles. So you'll have some discharge, nasal discharge that is basically full of spirochetes. That would be a sign or symptom. Evidence of congenital syphilis on a long bone x-ray. Anything in the CSF, cerebral spinal fluid testing, where there's a VDRL reactive or where there's a elevated white blood cell count or protein count without some other information, some other reason. So there's a couple of things that can actually cause a case to be a congenital syphilis case based purely on the infant. And then of course it's classified as a stillbirth, whether we know the reason for the stillbirth or not. You know, and sometimes, I mean, of course we don't ever really have a good understanding of that. But it meets the case definition simply if, oh, for goodness sakes, these stupid lights. I don't know. I may just be in the dark. It meets the case definition if the mom wasn't treated in time, period. So that's just kind of how congenital stillbirths work. So I hope that's a little bit clearer when you're looking at these numbers, because I think sometimes we hear 110. There were 110 babies born with like obvious congenital syphilis symptoms that they're going to have their whole life. And it's not always like that. We do have some very clear disparities when we're talking about congenital syphilis, and I think that these persist across all of our STIs. But you can see here that when we're talking about what we like to consider women of childbearing age, is we usually look at 15 to 44 years of age. And when you're looking at that, you see that American Indian Alaska Native make up 9.2% of the population, but made up 15.5% of our congenital cases. And this is when we're looking at maternal race, because we do assess things based on the maternal race. So we have the same sorts of disparities occur that we see in some of our other conditions, but maybe even more prominent here. As far as maternal information, there are 110 cases in 2022. It's an all-time high for Oklahoma. I will say that we're expected to see about a 30% increase for 2023. I think that's really awesome. I'm hoping we maintain that momentum. And I think that a lot of that is due to all of the work that so many people have done statewide to really tackle this. It's really quite something. Maternal age range is not surprising, 17 to 42. Something we've seen in Oklahoma really since 2017 is actually an increase in drug use. There's a lot more syphilis cases that are presenting with drug use as part of their history. And of course, this number is underestimated simply because not everyone is interviewed, not everyone is comfortable sharing their drug use. And I think we're also talking about a population that really would not want to share that kind of history because they are worried about, you know, their kids being taken or things like that. So they may not always share that risk factor information. And it's not necessarily a risk for transmission in and of itself. It's just something we're seeing happen among our clients that have syphilis. 74% had a prior STI. That's one of the biggest risks for having an STI is having previously had an STI. So that is not too terribly surprising either. As far as the timeline of that maternal diagnosis, so in 2022, 38% were diagnosed at delivery. So fortunately, testing was done at delivery. And so 38% of those were diagnosed at delivery. 12% were inadequately treated. So what this really means is there were either too much time between those bisulin therapies, maybe it was over 9 days, or something, or they didn't get every single number of doses that they needed, and they only got 1 or 2, and they needed 3, something like that. So there may not have been enough treatment, or it didn't happen before delivery. 20% were diagnosed or treated too close to delivery. So I was talking about that 30-day time frame really being the ideal time to start treatment therapy. So if it began day 29, if it began day 29 and the baby's born, 29 days later or something, that's diagnosed and or treated too close to delivery to prevent the CS transmission. Almost 14% were adequately treated, but the infant had reactive non-treponemal testing. So that would be like an RPR or a VDRL. And there were signs or symptoms consistent with congenital syphilis. So those are those kind of weird ones where it looked like we really did everything we could. The mother was treated in time, but for whatever reason, we had this situation and they ended up classified as a congenital syphilis case. And then unfortunately, there were 2 that were actually diagnosed after delivery. Those are things where clearly testing wasn't done at delivery, right? Those are normally, I think both of those situations were pediatricians that actually diagnosed the congenital syphilis. So prenatal care is increasing in at least these cases. So about 61% had prenatal care. Don't really know how robust that prenatal care was. We don't really have, number of visits and adherence and things like that. But it was an increase from 2021, but it was about 46% in 2021 and 39% in 2022. So it did have an increase from previous years. For those that did have prenatal care, over 3/4 were tested for syphilis at their first appointment. So that's good. Could be better, but it's good. 55% were tested at 28 to 32 weeks gestation, which is not great, of course. We're wanting that number to be a lot higher. And then 91.8% were tested for syphilis at delivery. So that's definitely been an increase. The testing at delivery is up from 72.1% in 2019. It was 83% in 2020 and 89% in 2021. So definitely seeing some increase in testing at delivery. So what does the testing and treatment look like? Who needs syphilis screening? I would say everybody at this point, but It's probably not realistic. So all of the pregnant persons need to be tested and or screened for syphilis. And then people who have other things. So suspicious symptoms, recent partners with a confirmed or suspected diagnosis, history of or current gonorrhea, chlamydia, syphilis, or HIV diagnosis, multiple sex partners, persons experiencing housing instability or any sort of recent incarceration, history of or current drug use, exchange for sex, drugs, money, or other needs, and persons who have no prenatal care. So really the recommendation is also not to discharge until results are known, which I know is really challenging for birthing hospitals. So Oklahoma legislation around this is we were able to get some pieces of the statute changed to at least refer people to the CDC guidelines. This went into effect November 1st of 2023. And basically it just says, if you're in the care of a pregnant woman and you're going to be possibly taking samples of blood or whatever, you need to send that sample to an approved laboratory in accordance with the guidelines for CDC. And so, of course, this then requires people to know what the CDC guidelines say, which is kind of like an uphill battle because they would have to go and look and research and figure out what are actually the recommendations. So that's sort of kind of our goal is really to make sure everybody knows what the recommendations are, what the state of Oklahoma is, so that they can kind of understand that we are a high morbidity state and that we do have large amounts of syphilis. So the actual CDC recommendations around persons of childbearing capacity and pregnant persons is to screen asymptomatic women at increased risk, history of incarceration or transactional sex work, geography, which is, I think, one of our biggest things is that, you know, you're looking at a state that's 5th in the nation for females age 15 to 44 for syphilis. We are in a high risk geography. Race or ethnicity for syphilis infection. All pregnant women at first prenatal visit, retest at 28 weeks gestation and at delivery if at increased risk due to geography or personal risk, substance use, STIs during pregnancy, multiple partners, a new partner, and a partner with STIs. And of course, a lot of those questions require really good history taking at the provider level. They require a conversation with the client to really understand their sexual health history, to be able to really assess whether they do have multiple partners or a new partner or substance use or any other additional STI risk. The treatment of syphilis in pregnancy is the only treatment is benzathine penicillin. That's it. It's bicillin. There's no other alternative. It is the only medication that can also treat the fetus in utero. So it is the main therapy for treatment of pregnant females. So pregnant women should be treated with the penicillin regimen appropriate for their stage. And then they would require desensitization if there is an allergy. And then, of course, treating partners is really the best way to prevent reinfection prior to delivery. As far as the treatment for primary, secondary, and early non-primary, non-secondary, for non-pregnant clients, it's a dose of bicillin. Of course, right now we're in a bit of a bicillin shortage. We're not able to order as much as we would like. So we have prioritized different persons for receipt of bicillin, and really the main priority population is pregnant persons. We also are prioritizing clients that are diagnosed with HIV to receive bicillin, and then every now and then we'll have a situation where we know there's an adherence issue or some other situation. Like we just had one today, actually, like where somebody at the private level had already started a client on bicillin, and then they presented at one of the county level, and so that was continued on bicillin because they had already started and they needed the 2 more rounds. So for non-pregnant clients, bicillin is still what we would prefer. Someday we'll get back to that, but doxycycline is also available. For pregnant persons, it's going to be bicillin ×1. CDC does kind of recommend to have a two dose, so they would do it twice. Second dose, really given at a 7-day interval. And if the person's allergic, then it would be a referral for desensitization and or skin testing to find out if they're actually allergic. So then treatment of unknown duration or late, when you've had syphilis a little bit longer, it takes a little bit more to treat. So for non-pregnant clients, it's bicillin in 3-week intervals. Or no, I'm sorry. in 1 week intervals for 3 weeks. If they're allergic to penicillin, then it's doxycycline for a longer duration. And then for pregnant people, it is again three rounds of bicillin a week apart. They have said that 7 is really the ideal timeline, and then missed doses beyond 9 requires a treatment restart, basically, which you can imagine is pretty difficult, and probably why we saw some of those numbers we saw for women, or where the treatment was too far apart. And we ended up with congenital syphilis cases. It's really about the ideal time frame for treatment to occur. So pregnant women who miss a dose must repeat the full course of therapy. And then this is just sort of something that we always share with the like the county health department nurses and stuff, but clients should remain in clinic 20 minutes after treatment. Neurosyphilis and ocular syphilis. So if there's neuro or ocular involvement, you always treat the stage first. Well, I'm not entirely sure if it matters if it's first or simultaneous, but you treat the stage of syphilis, and then they would be referred for additional IV therapy for neuro or ocular. Because you can actually have neuro or ocular at any stage of syphilis. We've seen ocular in secondary syphilis when it used to be thought that that would only be something that would happen in like later stages of syphilis. For pregnant persons, appropriate treatment regimen needs to begin at least 30 days or more before delivery. And then, of course, pregnant women who miss a dose must repeat the full course. So I did kind of just want to take a couple of minutes to talk about the Sexual Health and Harm Reduction Service and some of the stuff that we have and in areas we can help. So our mission is to protect and promote the public's health by intervening in the transmission of HIV and STIs. I feel like I should also add viral hepatitis here, and we have done some harm reduction work as well. So I just want to share real briefly our org chart. We're divided into 4 areas. We have an area of Ryan White care delivery. We have an area of prevention, an area of intervention, and an area of surveillance and analysis. So the Ryan White care provides care and treatment for persons living with HIV who qualify for assistance. It pays for insurance premiums and copays. It does medication assistance for persons without insurance. There's a Positive Peers app that kind of links persons diagnosed with HIV for community support. Provides medication and laboratory testing. It covers the costs of medications and laboratory testing for our Rapid Start program, and it monitors, audits existing contracts for care delivery. We have several across the state that are contracted with our care area. It evaluates outcomes according to performance standards, training and technical assistance to contracted sites, and it has linkage to care case management for persons living with HIV who've fallen out of care. So working to get persons back in care. Our surveillance area, a lot of data collection. So syphilis is reportable to the health department within 1 business day. Surveillance kind of gets those, filters through them, figures out what needs to happen, if it's new, if it's old, if it needs to go to a DIS, if it needs to go to field staff. They just kind of go through a process there. They provide training, they provide data, they present data, they do things like I'm doing now. They'll talk to people just about what's going on and have a presentation conducted. They will also do active surveillance and follow-up in cases of public health importance, also called COFI cases. We'll do perinatal HIV exposure, perinatal hepatitis B. I think I saw Rebecca Baker on the call. We do congenital syphilis follow-up and provider and laboratory reports missing information. Our prevention area provides HIV CTR training, does hands-on HIV and HCV rapid testing, training and certification. It conducts an STI academy, which is, it's mainly for the county health department nurses, but we've had a few private providers also attend and some from IHS as well. But it's basically a 2-day intensive where we talk about everything related to STI. It monitors contracts between OSDH and our community-based organizations that provide HIV, STI prevention activities and testing services to the public. It provides education and training for viral hepatitis prevention, HIV, STI prevention, promotes HIV, STI awareness and risk reduction. That is also where our Rapid Start program and our PrEP program are housed. So you may, meet clients with high risk for HIV, and they can be referred to our PrEP program. And if there are clients that are diagnosed with HIV, then they can be referred to our Rapid Start program, and they work to get clients on ART within 7 days of their diagnosis, which is amazing when you think of how far we've come. That is also where our condom distribution program is, and I'll show you how you can order condoms for your organization, and also how you can have your clients, if clients want to order condoms, they're shipped in a discrete package to their house. Supports harm reduction programs with supplies, technical assistance, and training. It's also where our public health detailing program is. It has some community planning groups, and it also does outreach events. So here's an example of our condom card. You can buy them, they're free. I'm sorry, I don't know why I said buy. You can order them on the website for either your facility or person. There's 2 different kinds of ways to order. And then we have our area of intervention. Our area of intervention is really where our disease intervention specialists are housed, and they can be a really great resource for you all. So I am going to talk a little bit about kind of the stuff that they do. They provide services for really linkage to care services for clients that are diagnosed with HIV and or STIs. They also do partner services. So what that means is that they would have an interview, talk about their partners, figure out who they needed to go and test and or refer into the health department. So they're basically boots on the ground is kind of how I think about it. So they'll do testing and referrals. They do outbreak management and response. They're working very closely with the county health departments and IHS. Most recently, there's a lot of events that they're doing where they're testing. A lot more outreach is happening. Outreach and screening events are happening with our DIS, which is really great. So what are DIS? They're highly trained public health professionals who use contact tracing and case investigation to prevent and control infectious disease. So primarily, we're talking syphilis and HIV in Oklahoma. That's really what we follow up on from a DIS perspective. But they have also kind of helped with the COVID-19 response in the past, and they help with the Mpox response. They specialize in public health investigations, case management, provider and community engagement, and outbreak cluster detection and response. They are investigating pretty much all of the syphilis and HIV cases in the state. Depending on what's going on, it may not get the same level of work. So they prioritize our primary and secondary cases, and they prioritize pregnant persons. So case investigations and contact tracings work the individual who is diagnosed, but then also works partners and or contacts to that person who may have been infected or exposed. So they're doing risk assessment. They're discussing transmission. They're helping with staging, because a lot of times somebody may not have any symptoms, but throughout the interview process or by working their partners, they learn that they did. They said that they had something, and they describe it well enough to where we can get a better timeline of when the syphilis infection may have occurred. And they also have contacts that may have been infected and are staged at a different level, which helps kind of understand their staging. They assess signs and symptoms, and they're really trying to kind of do risk reduction, and they also encourage future testing. So really, the DIS can be a good resource for you all. They can make sure that you have access to the most recent treatment guidelines. They can also look up STI history if you've got a question about previous testing and or treatments. So if you have a client who presents there and you're needing to know tighter history, or if the person's been treated before to really guide kind of your treatment path forward, you can always call, but you can also call, I'll give you a few phone numbers here at the end. You can also call surveillance or the DIS to kind of help you with that. They work with the county health departments to do appointments for treatment and notification of reactive HIV syphilis results. And they'll answer any questions or concerns that you might have about testing and what treatment might be adequate based on individual staging. So we have multiple DIS. They're kind of broken up across, I think this may not be the most up-to-date map now that I'm looking at it. I think it was redone to be similar to the regional areas that our county health departments use. But this is sort of how it's broken up, and I'll try to get a most recent one over to probably to you, Denise, that you can disseminate accordingly. We also have a maternal DIS team whose main focus is pregnant persons and making sure that they're linked to the treatment and care that they need, making sure that we get a really good amount of information from them so that we can, prevent future cases, and so that we can make sure their partners are treated. So we have 3 areas. We have kind of like the Oklahoma and then Oklahoma County area, almost like the MSA. And the Tulsa, actually, it looks like it is literally the MSA now that I'm looking at it. I think it's Tulsa MSA and Oklahoma MSA, and then everything else is sort of how they're broken up right now. While we're broken up into those 4 areas, we do have quite a lot of collaboration that's happening across them. And some of these are some of the things that we are working on for combating syphilis in Oklahoma. We have our STI Academy. We have some syphilis educational webinars and trainings, which I'm going to talk about in just a second. We've got one ready for you guys coming in hot. I'm real excited about it. And then we have persons that travel the state to just go, like wherever they are asked to come, we're going. And so we're always talking about syphilis when we go there. And then we have our review board and our task force. We have our OHHPC, which are Oklahoma HIV and Hepatitis Planning Council, Oklahoma Hepatitis Elimination Council, and the Oklahoma Harm Reduction Council. So just some different things that we're all a part of, and it all sort of integrates to address all of our things, but syphilis seems to find its way into the space of all of those. We have some social media promotion we're doing. And then again, we have outreach committee that plans outreach events. And we have our outbreak response plan that we're constantly developing and reviewing. And then we have an EHE integrated prevention and care plan that drives a lot of our work. So our upcoming educational opportunities, there are actually 2. One of them is a webinar really to cater to you all, actually, where they're really going to go through the pathogenesis. They're going to go through all of that of syphilis. They're going to do an in-depth presentation on the clinical signs and symptoms and the testing, and you'll get a little bit more epi data as well. We are partnering with Denver Prevention Training Center on that. They've been really good partners for us, and we work closely with them on all of our syphilis events. So they will be offering the CEs, and I will have an invitation for you all to disseminate as soon as it is gone through our Office of Communications. We have an in-person syphilis event in November. It is in Tulsa. It's kind of a repeat of something we did last year. We're just doing it on the Tulsa side. So we do have 2 upcoming educational opportunities. And then we have an after hours on call line. If you call this week, it's me. So I will be the one who helps you. So this is really for in the evening and on weekends, and you can call that number. And then we have our SURE service line. So if you have questions about treatment history or titer history, you can call, during the day, and we'll get someone to help you. And then there's my contact information if you have any questions.
Thank you so much, Amber. That was a very informative presentation. Really appreciate it. It looks like we've got a couple of questions in the chat. I might start with Emily wants to know, are these resources listed on the department website? She'd love to share it with the hospitals. She's with the Oklahoma Hospital Association.
Okay. Well, the condoms, for example, are actually ran through our OHHPC website. So I don't know if they're directly linked on the website or not. And I'll be the first to confess to you that I need to take a look at our website and make sure that it is up to date with all of the right resources. So I'm kind of guessing that it is probably not updated on the website. Not at least, I don't know if the DIS map is even on there. So I'll have to look into that. That's a good question.
What we can do, Amber, is if you want to update your slides, once you do have the links to those resources,
Okay.
we will send a copy of the slides out to all
That
the
sounds good.
participants, so we can make that link available there.
Yeah, I'll put the link to the condom ordering on that same slide. I'll just kind of put the link to it. I think the QR code actually takes you there. But I'll put a link anyway. And then one thing I did want to mention is that we do have a DIS video that's going to come out. I just heard from Office of Communications today, checking in on whether I had gotten it yet. So I know they're working on it, and I know it's very close, but it just is sort of a way of kind of informing people about what a DIS does. And so I'll make sure and send that to your way when it's done as well.
We also have a question from Melanie. She wants to know, do we know why this increase in cases has happened?
That's a good question. I think like my first answer is probably gonna be something like substance use, simply because it just really exploded in 2017 among our syphilis cases. It just overlapped so much. I'm not exactly sure why. I think that that's really, I mean, you have an overlapping epidemic of substance use and so many things actually, but STI is in there. And I think that's part of it. We did for a long time have a lot of increases in anonymous partners and meeting persons online. Although I think more now it's really related to the communities where there's a lot of drug use and substance use happening. So I think that's the one of the things I would point to probably. Syphilis is also really tricky. It looks like a lot of other stuff. It's really hard to diagnose sometimes.
Any other questions for Amber? All right. Well, thank you so much, Amber.
Thank you. I appreciate it.
And next we have Kelly McNeil. So Kelly is the Pregnancy Resource Navigator Coordinator for this new program that we're very excited about, Family Support and Prevention Service. So Kelly, I'm going to turn it over to you now.
So like I said, this is the PRN program. You want to go to the next slide? I'm going to start out really right from the beginning to give you a little bit of foundation and background about the program. So this program actually started as a recommendation from the Governor's Help Task Force. Initially, the objective was under encouraging and providing resources to communities to support unplanned pregnancies. It somewhat morphed over the course of that task force. And the official recommendation ended up was to seek support for Pregnancy Resource Navigators, or the PRN program, by the Oklahoma State Department of Health, to expand home visiting and case management services to support and celebrate Oklahoma mothers, babies, and families, with request for funding if needed. Clearly, funding was needed. And so with state appropriated dollars, OSDH really began working with other family serving partners and developing the PRN program. And our mission is supporting Oklahoma parents and babies before, during, and after birth. So that's how we got started. Next slide. This is really, I kind of call it our elevator speech, because, you know, when people say, what are you really trying to do? This is typically how we answer them. So PRNs are working with communities across the state to provide access to resources, to programs, and to services that support pregnant and newly parenting families. And we'll talk a lot about that in a minute, about what that means. And then we do that through a vast network of home visitation programs, partnerships throughout the state, and again, those family serving organizations within each of the communities. Next slide. So what does pregnant and newly parenting families really mean? Well, clearly, and especially to this group, we don't really need to describe pregnant. Either you are or you're not. But newly parenting families really ended up being a little more challenging than we initially thought for folks to really understand what we were talking about. And we use this language really because we're trying to capture those families at their most vulnerable time. So as we all know, that's right after giving birth, right? Those newly parenting families, it may be the first time that they've given birth, or maybe the last time. Either way, they're newly parenting this child, and that really can change the family dynamic. So we kind of expect first-time moms to be a little anxious, you know, when they're expanding their families and starting their families rather. And then those folks who are expanding their families, it can become just as complex, maybe in a little bit different way, but there's still concerns. And of course, we typically think about finances first. But then there's other ways that maybe it's someone who's moved to a new community and they don't have a support system. It could be someone that maybe has issues with their partner. So either they're just not there, or maybe it's domestic violence in their home. Either way, there's a lot of concern around that time, and it just becomes far more complex when you have that newborn in that family, right? It really escalates some of the complexity of that. So what we want to do is support those families. So we really need to support those families throughout our state to make sure that they have all of the resources that are available to them. Keep in mind, this is not for any one specific group. We're a universal program, so we're open to anyone who is pregnant or newly parenting. And I often talk to the PRNs, and we'll talk about them just a little bit more here in a little bit, but we talk a lot about making sure that we're not just looking at folks who are maybe have a lot of needs, like their finances and those kind of folks that we see often come into the health department, but that we're also trying to help those that maybe have never accessed any of the services from the health department. And we don't want to overlook them. Sometimes, we think that because they may be better off financially, or maybe they have a lot of family in the area, that they have a lot more support. And sometimes those folks are really, really in need as well. And so we want to make sure that we have touch points with every family if they're pregnant or newly parenting. And then again, I want to go back to, and we've been questioned a lot about up to how old. Again, this is a universal program. So we want to reach out to everyone, but we do track data on those families up to when that infant is 6 months old. Now, that doesn't mean that if someone comes in and they're have a 7-month-old, that we're not going to help them. We're going to continue to help them in any way that we can, with any resource or service or referral that we can do. But we're really just going to track the data up to that 6-month time. We kind of had to put a time at which we can track and find out what's going on with those families initially. And so we kind of chose that 6-month cutoff time. So not for services, just on the data side of things. Okay, next slide. So who is a pregnancy resource navigator? Well, hopefully by now you all have heard of community health workers, and they've been in and around our communities for quite some time. We talk about them often as those people with lived experience. They're really members of the community, or they have a really close understanding of that community that they've served. But as a PRN, they, in addition to being a CHW, they have an extensive working knowledge of those resources and those services for pregnant and newly parenting families. So simply put, a PRN is a community health worker who has expanded knowledge of those resources to help pregnant and newly parenting families. So that tells you a little bit about who we are. And so this is going to tell you a little bit more about kind of what the expectations were. These are directly from the task force, what they wanted us to do. Again, provide new mothers, parents, and babies with the support and care they need before, during, and after pregnancy. You saw that as really our mission statement, if you will. We are to emphasize the importance of meeting basic needs with the families through protective factors. And you'll see this a lot in our training, the trainings that we do with the PRNs, to really work with families from the point of really promoting those protective factors. So what is really working for those families, and then build upon that. We assess and assist in signing up for Medicaid. That's a big part of what PRNs do, making sure that they connect with folks. As you all know, one of the first things that we need to do if someone knows they're pregnant or thinks they're pregnant is making sure that they have access to care. So we want to do that through the Medicaid program, and then also through other health services that we can refer folks to as well. We want to serve as a critical access point to services. I have no doubt that you all have heard over and over again, as I have throughout my tenure with maternal and child health, that families telling us, I just didn't know about this program, or I wish I had heard about this program. Well, we want to kind of change that course into having community folks start to share, did you know about this program? You know, they've got some great services for you to help you with. And so we want to serve as that critical access point, that resource for families in the community. Utilizing technology to assess expertise, and we'll talk a little bit about that a little bit more, how we're using technology. Utilize trained workforce of CHWs to connect to families. This was initially really problematic for us because while we were funded through state appropriations, we had a hiring freeze. We could not, you know, hire other folks to come in the positions that we had originally written for. And so, but we've kind of been able to turn that into really one of our biggest blessings. So the problem was that we couldn't hire any other new CHWs. So we turned to the Office of Community Health Workers and began using their personnel who were already in the field, which really allowed us to jumpstart this program. We already had people who were trained on certain levels. We've done some additional training since then, but they were really able to get this program off the ground very, very quickly. And that ended up being what was one of our biggest challenges into one of our biggest blessings. So we're very, very excited to share some of that information with you as well. And then ensuring follow-up for critical services needed for success. Again, you can make those referrals, but how do we follow up with those folks to know that that's really happening? And so this is one of the things that the PRNs are going to be able to do. Next slide. And one of the things that we were asked to do is make sure that we celebrated those births. So we are able, all the families that work with PRNs are able to hand out these, our littlest Okie onesies to all of those families. So I wanted to share that picture with you because those have been very well received. And so we're able to celebrate all of those healthy babies. Okay, next slide. So I've kind of told you how we got started and who we are. So next we're going to talk about our pathway. So this is something that when I came on board, we wanted to put together what exactly did we need to be successful. So we came up with each one of these. So if you want to hit it one more time, Denise, on the training. So again, start with those trainings. We had those CHWs. They already had a core training schedule that they do. It's very generalized and they get a lot of training on a lot of different health issues. As we came in, we now require additional training, 48 hours actually of additional training, focusing specifically on serving pregnant and newly parenting families. So this is going to be things like our safe sleep training. It's going to be Period Purple is in there, and several other different things are in there that we do. In addition to those trainings, they also have a monthly meeting where presentations about services and other programs are also given to them. So they learn about that. And every quarter, they do a 2-day training. So these folks are very, very well trained and have a lot of knowledge about not only their community, but what's going on in their community and what services are available in their community. One more, engage. So again, all of these are really forming around that pregnant and newly parenting families. We want to focus on those social drivers. So meeting those families where they're at, where they live, work, learn, play, and pray. That's where we want to meet those. And resources, and this is one for this group, I think is going to be really important. And we're going to dive a little bit deeper here in a moment. But PRNs are really going to provide those essential services. They're going to have referrals to programs, links to initiative, and support for those families. In places where there are no services, say there's not a Children's First or something like that, then those PRNs really step in and have those touch points with those families. So they're able to support those families in that way, making sure that they get as much as we can possibly offer them in the way of services. Looks like there was something in the chat, and I'm going to tell you in just a moment how you can refer to the program. Outreach. So clearly, again, you need to know about the program. You need to raise awareness of those existing services as well as the services that we offer through the PRN program. Collaboration then. This is really either something's already available in their local area or build upon what's already there. So we kind of work in twofold in that way. And also, this isn't only for the PRNs. Sometimes this is for their regional directors or the supervisors or whoever's appropriate, but to have those connections and really work in tandem with what's going on in their local communities is really, really vital. And then again, data and evaluation, always important. We collect a great deal of information through our efforts to outcomes. That's that ETO in reporting and establishing that. And what we really want to do with all of that data is find out what's working, find out what's not working, figure out where the gaps are, figure out where the trends are, figure out if what's working in one area of the state, will that work in another area of the state? Well, one community, something might work and something else. So very fluid, very flexible. But to do that, we really have to stand on that data so that we can be evidence informed and find those strategies that work and find those solutions. And then, of course, once we do that, and once we tell our story, and once we find out what's working or what's not working, then again, we do that additional training. And this is just a continuous quality improvement program to make sure that we start again on doing all of those steps. Before we get started, was there a couple of questions maybe that I think I can see?
I see one comment on the design of the onesie and several thumbs up in agreement to that. And then Melanie wants to know, how do we refer to the program?
Yeah, and we're going to get to that in just a few minutes because I want to show you specifically how to do that. So this is, again, part of the essential resources and referrals that we have. Internal resources, internal meaning at the Department of Health. So we have WIC, Children's First, Parents as Teachers, Parent Pro, Warm Line that helps with behavioral health, injury prevention, including car seats, child guidance, immunizations. All of those are referrals and resources that we have. Not always in every area do we have all of those. Not every area has Parents as Teachers, but if they do, then we want to connect with that. What we're really trying to do is not reinvent the wheel. If someone qualifies for a program or meets those qualifications, we want to be that warm handoff to them. We want to make sure that they have access to that. But in areas where there's not those services, then we want to try and fill that gap the best that we can. So that's the internal resources that we work on. External, I've listed some here as well. Food banks is a big one. As we know, this state is very food insecure. So we want to hook folks up where we can there. Child care resource and referral, how to get those little ones into child care if that's necessary for that family to survive. Housing, again, Medicaid, sooner care, health insurance, the quit line if there's tobacco use, and on. Then all of those resources. And then there's quite an extensive list that each local area has.
Kelly, we have 2 more questions.
Okay.
Priscilla says, is it only for first-time pregnancy or any pregnancy?
Any pregnancy, again, a universal program. If they are pregnant, we don't care if this is their first or their 10th or anything in between. So we can do that, and there's no income eligibility as well.
And Becky, Thank you. And Becky also has a question. Do they have referrals for the Oklahoma Breastfeeding Hotline, lactation consultants and community, et cetera?
Yes, they do. That is the short answer on that one,
Thank
Becky.
you.
We make sure that they do. Every week there's a weekly email that goes out, and I include, especially for on the maternal and child health side, a link or a resource or what, so they get that literally weekly to be able to learn all of those resources, as well as they use. And I think the next slide will even help us with that a little bit more. Can you go to the next slide? There we go. So clearly we use maternal and child health resources that we already have. So in the Preparing for a Lifetime information, they have access to all of that information. And then I make sure and go through that whole list as often as I can. Every week they get another one to really focus on, and make sure that they get as much of that information as they can. That there's a lot of folks right now. Initially, we were to have 20 PRNs. And then again, like I said, the workforce kind of shifted to using the already established CHWs. And now those folks are getting cross-trained. And so we're talking about over 50 individuals across the state now that are getting all of this information on a consistent basis. Okay, next slide. I wanted to throw these next couple in just to make sure that you all understood that we want to connect with you in your local areas. So we talk a lot about how we work in the community. So with local groups, nonprofits, family serving organization, the faith community, working on health fairs, social media, if that's appropriate. Again, and give a shout out to Joyce and all of her group for the county information. I talk a lot about making sure you understand your community and what's working in that community, and getting on those dashboards and seeing what's working in your community and maybe where there's gaps in services, and then really trying to fill in those areas. And so we use that county information a lot. And then of course, building relationships with hospitals, doctors, and local healthcare providers. In some areas, we've done a really great job with that. We even have one working on even being embedded in the hospital areas, and those are working very, very well in those areas. And others are on the way, kind of developing their campaigns as we speak. Next slide. Again, collaborating. We don't want to come in, and I've said this already, but I'll say it again, not to reinvent the wheel, but to build upon what's already there, to build upon what's already really working well, and finding out if there are gaps in services or where we can kind of fill in and do those kind of things in the local community, which takes a lot of collaboration. And I'm really excited about what I see in some of the communities, and how excited some of the kind of non-traditional partners are really starting to come to the table and understand the importance of working with this population. And this is where we're going to get and probably may stay here for just a minute, just so we can share a little bit. I wanted to show this slide for a couple of reasons. So we started this program in January of this year. Initially, we piloted in 4 counties. So that was Garfield, Comanche, Muskogee, and Rogers. And we're going to kind of see how things rolled out with those. Within a matter of weeks, Garfield wanted to add a couple of counties, and Comanche wanted to add a couple of counties. So really, in that first quarter, we ended up with 8 counties that we were working in, trying to see how things were rolling out, and the excitement kind of escalated quickly. We had a rollout where each of the local health, through the State Department of Health, our local districts, through all of those districts, we were going to roll out, one hub county, and then we'd add 2 more, and then we'd go countywide. And we've kind of blown that out of the water. because as of May 1st of this year, we literally have 40 counties that have CHW PRNs working in that county with us right now. So we have just gone gangbusters. As you can see, we still are rolling in a few other counties. Most of the counties that you see that will be expansion counties, either one, don't have a local health department in them, or they're sparsely, we just don't have the capacity actually to cover that county at this point. And so we're working desperately to see how that's going to be. We still have an FTE issue in that we can't hire new folks right now. And so at some point we will hit capacity, but right now these folks across the state are just working feverishly to get everything going and making sure that we're hitting this population. And I just couldn't be more proud of how quickly this program has rolled out. Initially, we wanted to be statewide by the end of the year. As I said, we have a couple of barriers here, but we're still on target and moving that direction right now. Next slide, and that one's going to show. Okay, so this is our website that you can go to. And Denise, I don't know if this will work really well for us, but if you click on the website, it should take us there. I'm going to show folks the easiest way to find out who's working in their county. Okay, so you don't have to do this, but if you hit on any one of these tabs, a pregnancy or whatever, you're going to get a lot of resources. And if you'll scroll way down past the video, right there on Find Services, if you'll click on that, and let's pick Comanche County. Let's go there and scroll down just a little bit. Then you're going to see Amanda is working as a PRN in that area, and that's her direct line. If you scroll down a little bit further, and you click on any one of those other counties, it's going to take you straight to the county health department number. And by calling that number, they should be able to connect you if they have a CHW PRN working in that area. So any one of those can do that. But the ones, some of the counties have decided to literally put the name of the PRN that's working there and their direct contact information. So that's two different ways that you can reach out and refer to them. Does that answer the question? Sorry, I forgot who asked it.
I think that was Melanie's question. So Melanie, let us
was
know
that.
if
Melanie, does that answer your question?
It absolutely does. And I am so excited about this. Thank you so much.
You're very welcome. Okay, if you want to
we
go.
had another question. It's Tulsa, and I'm going to also add Oklahoma counties. Are they not included because they have family advocates?
No, they are not included right now because our focus has initially been on rural communities because they lack so many more resources than the metro areas. There is in our program, we will be reaching out to Tulsa and Oklahoma County, but it may look a little bit different. And to be honest, like I said, we just launched in January, so we're just simply not there yet. But yes, there are family advocates there. So the other part of that is if we do have someone that calls for whatever reason, let's say they're in Canadian or they call Canadian County, but they're actually an Oklahoma County resident, we'll end up finding them access to as many resources that we can connect them with. Again, it doesn't help our data and doesn't do whatever, but at the end of the day, we all are about supporting all pregnant and newly parenting families. And so we'll get them as many resources as we can. We just don't have anybody designated in that area today. Data collection. Again, this is one of our pathway and making sure that we connect with the data and the evaluation. This is really important when we also look at those referrals that are made and followed up on. So right now we use ETO, our efforts to outcomes, which is internal at the health department. So for instance, we can make a referral to C1, or we can make a referral internally through that. And if you go to the next slide, coming at the end of this month, so in just a couple of weeks, we're also going to use the Unite Us platform so that we can connect and make those referrals outside of the health department to those local providers and nonprofits and other resources that are out there. And this platform is really good for us because it's that closed loop platform. So if a referral is made, we're going to know that that family was able to receive those services, or if they weren't. And if they weren't, then we're going to be able to reach back out to them and have an additional touch point to find out why, and or to help them get an additional resource, maybe in another direction. Maybe that program just didn't work for them for some reason, or whatever the case may be. So we're going to make sure that we have that closed loop platform through the Unite Us technology, and we're going to start that. It will actually launch the end of this month, so we're very excited to get that off the ground as well.
And I think, Becky, did you have a question?
Yes, a couple of questions. So it looks like for just referrals, we go through the website and find the county in question or where a particular person is, because this is information I'd want to make sure that our breastfeeding hotline LCs have access to. And then do the PRNs, are they getting or plan to get any kind of breastfeeding training? Because the C1 nurses, the parents as pros, all get a 2-day course that we offer on breastfeeding, basic breastfeeding.
Sure. They have some basic information right now. They have information on how to get to the milk bank, say, and all of those kind of things right now. They have all of that. We've done a small training on that. And I believe at the resource fair, we just had a quarterly training, and they had a resource fair there. And I believe that the milk bank was there as well. And so they got a lot of information and resources and got to communicate with the folks there about what was offered. But we just kind of do that kind of continual training. And we can look into that a little bit more, Becky, if you're wanting some more additional training for them, we can sure look into that.
Okay. Okay.
Okay, next slide. See, I get going and then I get all excited about you all asking these questions. So again, this is the state map, just so you kind of get an understanding of the different districts. District 10 is Cleveland County, and they have not been launched yet, so to speak. But again, I repeat, in January, we launched with District 2, 4, 5, and 7. May 1st, we added the additional, so we're now in 1 through 9, all the counties except for the metro areas, and 10. And you can see our numbers, our case numbers. I wanted to share, actually, you're the first group that's got to see this because I just got them today. The case numbers that we had for January through March, again, I was very excited. Those first 3 months that we started, we were already at 744 families we were able to help. And just April through June, you can see how exponentially we jumped to 1,600 families. So they are moving fast and furious to help as many of those families as we possibly can. So I was very, very pleased with these folks. They're working very hard to make sure that we're reaching out to all those families in their communities. So wanted to share that slide with you. And then this is the easy one, but Denise, I just clicked on each one. So clearly we're providing new moms, parents and babies with the support they need. We have already emphasized, and basically there's just check marks on all of these where we've been able in just the first 7 months of the program to really start to meet all of those expectations. Again, meeting the needs of the families, assisting with Medicaid, being that access point. And you can tell with the technology, which we're using the platforms on ETO, and now we're moving to Unite Us as well, that we will be using that technology to make sure we have that closed loop system, our trained CHWs, and then ensuring that we really have that follow-up for those families. And so far we've been able to tick all of these off on those expectations. And then last but definitely not least, I always like to end with a picture of why we do this work, to make sure that we have those healthy babies and families out there, and my contact information. I've talked pretty quick.
Thank you, Kelly. I think everyone can see why we're so excited about this program. And does anybody have any additional questions for Kelly? I know we answered several during, but if you've got any more, let us know.
I have a quick one.
Sure.
Can these amazing people, can they so I'm the new Safe Babies community coordinator for Wagner County.
Mhm.
And one of the things we need is to have an active community team that addresses the issues of the community for the pregnant mom. Like Wagner County doesn't have a birthing hospital. We don't have an OBGYN, like that sort of thing. So could they come to those type of meetings that are community-based to improve those conditions?
Absolutely. And I can send you and connect you with Jessica, who is the supervisor in that area, and make sure that she can get someone out there in Wagner.
I am so excited. You don't even know.
Happy to do it. You know what? Let me do this. Let me put my information in the chat, and if you will send me an email to make sure that I don't forget, and I will send you that information.
Wonderful. Thank you so much.
You bet.
Thank you. And we will also have Kelly's information in the slides and in the follow-up email that you should all receive after the meeting. So Kelly, that's really exciting news. Thank you again for sharing why we do the things we do. I think that's why we're all attending this meeting this evening, and just so excited to see how we're able to collaborate and share resources to try to achieve our common goal. So
Absolutely.
thanks so
I
much.
appreciate you letting me talk.
So as we continue on, we just want to have a few updates that we're providing from our team with OPQIC. Joyce kind of alluded to this at the beginning, but just to emphasize, we're still working hard with Team Birth. We are currently in our final cohort of hospitals, to where we have 9 that are joining, which we'll get to all 43 of the Oklahoma birthing hospitals participating. They will launch Team Birth, anticipating sometime in September or October. So very excited for us to continue on with Team Birth. And related to Team Birth, we have the first Oklahoma hospital that was certified by Ariadne Labs. They're the group that developed Team Birth and is helping us to facilitate across Oklahoma statewide. But OSU Medical Center was the first Oklahoma hospital to be recognized as a Team Birth facility. They had to go through some processes to try to prove that they are implementing Team Birth to its fidelity. They are one of the first 6 hospitals nationwide, in addition to being our first hospital statewide. So congratulations to OSU Medical Center. I know that we have had some other Oklahoma hospitals who have also applied and began the recognition process. So we're looking forward to more announcements to come. And then Katie Morgan, I'll let you go ahead and provide our update on our OB readiness project.
Perfect. Thank you, Denise. Like she said, my name is Katie Morgan. I am one of the program managers with OPQIC. Joyce did a wonderful job already kind of covering this. Our OB readiness in the ED initiative has launched its first part. So we did the A1 obstetric patient safety workshops. We had 4 workshops with 74 participants, and those were a wonderful mix of L&D and ED providers that came, and they collaborated so beautifully. 11 hospitals were represented, 6 other organizations. We are planning for another workshop in early 2025, and then hopefully in the fall again of 2025. Thank you again to the State Department of Health and Joyce. We were able to get funds to purchase 11 Mama Natalie's, and they have all already been allocated out to the hospitals. They were very, very excited about those, and those are going to be wonderful for them to be able to have their own scenarios and be able to take everything that they've learned back to their hospitals.
Thanks, Amara. We have a comment for Amari that she had attended the training and loved the different ways to interact for participants. So we are hoping that the word gets out on how great these workshops were and that we can continue to have further participation. Really reaching out, like Katie mentioned, to a lot of our hospitals that may have an emergency department but do not offer obstetric services. So if they do happen to have a woman come in either in labor or with an emergency related to her pregnancy or even her postpartum period, that they will be able to more appropriately care for her. So exciting. OPQIC also has a big announcement to make. Some of you are already aware, but we will be transitioning from the University of Oklahoma Health Science Center. Our staff have been employed there for many years. To now transitioning under the roof of the Oklahoma Hospital Association. So it will be a staged transition. We all will be transferred over by October 1st of this year. So stay tuned. We are going to be experiencing some moving pains. We're going to be changing email addresses, Zoom links, and anything that you can think of whenever you're making a big transition like that. But we're very excited for this opportunity. We think that it's going to expand our horizon some, provide us with more connections. We'll still continue our important work and hopefully to be able to expand some of that. So continue to stay tuned for more updates as we embark on this exciting new chapter in our journey at OPQIC. And thank you so much to the Oklahoma Hospital Association for wanting to take us on. So again, we'll be changing email addresses and such. Because of that transition, we will be having our 10th annual OPQIC Summit on November 19th. And that will be the day before the OHA annual meeting. So we're working in conjunction with them. We are changing our location. So this year we will be having that day at the Oklahoma City Convention Center in downtown Oklahoma City. Our agenda is still in the works as well as registration. So be on the lookout for that coming soon. But go ahead and save the date for November 19th in Oklahoma City. And then we also want to let you know of a webinar series that is coming up that that's being facilitated through some funding from the STAR program at the Oklahoma Children's Hospital in conjunction with the Department of Mental Health and Substance Abuse Services. We have 4 parts, as you can see. Starting August 22nd will be our first webinar series. They're all around 11:30 a.m. So we're hoping that you can grab your lunch and come to your computer and as you're eating, have some enjoy these topics that are being presented by some experts. You can see the QR code there. We'll also have the link available in the slides and in the email. But we do hope that you will participate in this 4-part webinar series. There will be some CME provided. And next, I want to save some space. Becky was going to provide some updates from the Oklahoma Breastfeeding Resource Center.
All right, thanks for that, Denise. So yeah, I'll try to go through this pretty quickly. I know everybody's been online here for quite a bit. So a few quick updates and then an announcement about our TSET grant that we're excited about. So just some reminders, we still continue to offer our one-day in-person Making Breastfeeding Easier class. This is often requested on demand by hospitals, so I will take this to your facility. This is funded through our longstanding contract with the Health Department MCH section. So we are very appreciative of being able to make this training available at no cost to those that request it. So next slide, Denise. And then, oh yeah, click one more. I don't know why that shouldn't be animated, but anyway. And then a newer one that we developed is actually making breastfeeding easier for NICU families. So this would certainly be most appropriate for any of our hospitals that have, any level NICU from, a level 2 through a level 4. So lots of good topics there for staff. Next slide. And then just, reminders about some of our online trainings. We do have a 3-hour online training for providers, and there is a fee for this. And of course, there's a 50% discount for any of our hospitals that are working on baby-friendly designation, but providing some basics on breastfeeding management for any type of provider working in maternal child health. And it's split up into a shorter self-paced module. So maybe they can do this over lunch breaks and when they're sitting around in labor and delivery waiting. So, but making that easily available. And then next slide. And then of course our long-time online training for healthcare staff, especially for bedside nurses, and really anyone else that's working in maternal child health. And this is a 15-hour training on basic breastfeeding management as well. It's interesting. OU Children's just wrapped up their redesignation site visit for Baby Friendly yesterday and today. We said goodbye to the assessors just before noon, and when they come on site and they interview a wide variety of patients, both inpatient and outpatient, but they also interview staff and providers. So they ask a lot of the same questions of the nursing staff as they do of the providers, but the providers only have to have like 3 hours instead of 15. So good luck there. Anyway, next slide, Denise. And then this, should be of interest to everyone here, and also Kelly, for your PRNs as well, to make sure that we're just trying to get this out there. This was something that we developed during COVID when to help our hospitals when all breastfeeding classes and support groups and so forth shut down. So this is a free online little session on breastfeeding that has lots of pictures, lots of videos. It's available in English and Spanish to help get that important prenatal education out to families, ideally before they come to the hospital, but still certainly very appropriate early postpartum as well. And families can, do this on their smartphone, iPad, whatever. And thanks. Hopefully that would be good for the PRNs to know about. So that's a QR code and easy access to that. Next slide there, Denise. And then, a couple of other announcements. So anyone that is handling human milk, whether in a hospital setting, a hospital NICU, childcare setting, Habana's latest hot off the press 5th edition of Best Practice for Expressing, Storing, and Handling Human Milk just came out last month. And yes, I was the lead editor on this book, so I'm very glad to see this out in print, and I am done with it. Any proceeds from sales of this book do go to support the Human Milk Banking Association of North America, which is the nonprofit entity that oversees all of our nonprofit milk banks and sets the guidelines and standards, including for our own Oklahoma Mothers Milk Bank. Next slide, Denise. And just getting the word out. This is the Listening to Mothers 4 survey is now out there. So just trying to get the word out. Anyone that had a baby in 2023 can take the survey and share feedback on their pregnancy and childbirth experience. So trying to get good data. And the last time they did this survey was in 2013, and I still cite data from that survey. So I really hope they get a robust response to this. Next slide, please, Denise. And then lastly, we are excited that we were awarded a discovery grant from TSET, the Tobacco Settlement and Endowment Trust, and we're kind of calling this initiative Advancing Infant and Maternal Health Initiative, or AIM-HI. And this will really allow us to expand upon the great foundation of work that we've done over the past, 10 plus years with our Title V MCH funding. So next slide, Denise. And the goal of this, of course, is to continue to increase breastfeeding support and evidence-based hospital practices, with hopefully making a dent in our, sadly very high obesity rates, which was, one of TSET's goals. Next slide, Denise. And so our first priority, of course, is providing additional funding to rural birthing hospitals, just as your PRN focus, Kelly, was with the rural counties, where they often have a lot fewer resources, and then some additional funding to continue to support our currently designated baby-friendly hospitals. So next slide, Denise. And so what we'll be providing in this with any of our rural hospitals is maximum coverage, 100% coverage of all the fees that Baby Friendly USA requires. Some of our didactic online education for a limited number of staff each year. We have, this grant is over a 3-year period of time. And then we're launching as kind of a special early access to the Oklahoma Breastfeeding Hotline. And I can go into a little more detail on that here in a minute. But also a new component of that is a telehealth component to the hotline, with free prenatal and postpartum telehealth lactation sessions that we've wanted to be able to offer for quite some time now. We will help these hospitals implement use of donor milk on their mother-baby units with 100%, kind of a sliding scale coverage over the first few years. And then, of course, some travel cost to an annual leadership seminar for teams from each hospital. So, and kind of the estimated total of value for each hospital is about $35,000. And then our currently designated baby-friendly hospitals, actually maybe not 100% coverage, but additional support for some of the fees they continue to pay for redesignation each year. And some, of course, free online education and the early access to the hotline, and then support for sending at least one representative to our annual summit. So next slide there, Denise. And just so you can see, thanks to Sarah for putting this map together. So we have, of our 77 counties, we have 26 counties that actually have a birthing hospital in them. And as you can see, of those 26 counties, 8 counties have a baby-friendly, one or more baby-friendly hospitals, and those are have the little pink hospital icon in there. And then the green ones are counties with birthing hospitals, but no baby-friendly designated hospitals. And then if we look specifically at Oklahoma County and Tulsa County, the Oklahoma metro area has 5 birthing hospitals, 3 of which are baby-friendly designated. Tulsa metro area has 8 birthing hospitals, none of which are baby-friendly designated. So we need some help with our Tulsa crew. And then and we have 6 counties that actually have more than one birthing hospital in them. So next slide there, Denise. And then just to kind of give us one little factoid from some CDC research that came out last year, and why baby friendly is important, because it's pretty easy to I say pretty easy, it is easier, I should say, to at least increase your initiation rates, which is data we get from the state health department that's reported on the birth certificate. Did the baby breastfeed 1 or 2 times, in the birthing hospital? It's a lot harder to send the baby out the door exclusively breastfeeding. And that's what baby friendly can impact. And if we can send them out the door exclusively breastfeeding, then that's going to impact breastfeeding duration rates. Do they continue breastfeeding for the next several weeks or 3 months or what have you? And so here you see on this slide, just showing the impact that early formula supplementation can have on the risk of early breastfeeding cessation. And while it has a greater impact on our lower income families, it has an impact on all families. And so over on the left side, if they had early formula in the first 2 days, and then you can see the lower income families had 21% risk of early cessation and 17, but they all had a higher risk of early cessation. And then on the right hand side, the blue represents those that had early formula, so in the first 2 days in the hospital generally, and the red represents those that left the hospital exclusively breastfeeding. So significant differences in how many weeks they continued breastfeeding. So that's not the only, but one of the key reasons why baby-friendly practices in the birthing hospitals are so important. So next slide there, Denise. And so, yeah, so for more information, we do have some informational webinars coming up. One is actually tomorrow at 12 o'clock. There's the QR code to sign up for that. And then another one on August 6th. And we are very excited to be able to expand the work that we've been doing, and yeah, hopefully continue to bring some more hospitals on board with this. So I will stop there and see if there's any questions. And Denise, anything else you need for wrap up?
Priscilla had a question about, I think this was the mother survey. Does the survey capture delivery provider type or midwifery model of care?
I do not know the answer to that because I myself have not done the survey. But that's a great question. So yeah, if you know anyone that is eligible to do the survey and can answer that, and you could potentially email the organization that's handling the survey and ask that question. That would be a good question to know.
And Heidi wanted to remind us that August is National Breastfeeding Month, and that the theme is to nourish, sustain, and thrive. That more info from COBA will be coming with a free webinar on August 28th. And a new toolkit. So we'll make sure to include that, Heidi, in our follow-up slides. Any other questions for Becky before we move on? Or any other questions about anything else we discussed this evening? Okay, hearing none, we'll move on. We do plan to continue the quarterly meetings at our same cadence. So our next scheduled meeting will be on October 15th. Again, from 5 to 7 p.m. via Zoom. You can continue to register if you want to be added to our recurring invite there at our opqic.org registration page. We will be changing, like I mentioned, as we transition to the Oklahoma Hospital Association, that Zoom link will change. So anticipate in the next couple months to receive a new updated Zoom link. So again, we'll be sending out this information to everyone. A reminder of some upcoming events. We do have the Project Echo that is recurring. I'll emphasize the congenital syphilis webinar that Amber was mentioning earlier. That's going to be on October the 9th. We will have registration for that event coming out soon. And then don't forget to save the date for the OPQIC Annual Summit on November 19th. Thanks so much to everyone for joining, for participating, for asking questions. We appreciate your collaboration and your involvement and all the things that you do to help Oklahoma mothers and babies. If you want to continue to follow OPQIC, here we are on our socials. Go ahead and snap those, but we are trying to get the word out and disseminating all of our work through our various platforms, and would love for you to follow us and subscribe and like all the things. So again, thanks everyone. We really appreciate your attendance this evening.